Hello, it's my pleasure to welcome everyone to today's summit, Optimizing Advanced NSCLC Biomarker Testing, Treatment, and Management. My name is Dr. Dan Milner, and I'm the Chief Medical Officer of the American Society for Clinical Pathology. ASCP is the world's largest professional membership organization for pathologists and laboratory professionals. With more than 100,000 members, the Society's influence has guided the application and evolution of the pathology and laboratory medicine specialty since 1922. We're really excited to collaborate with the Association for Community Cancer Centers to bring members of the interdisciplinary cancer care team together for today's summit. We have a great lineup planned for you. 3 90-minute sessions designed to provide you with the information and resources you need to partner together with your colleagues on the interdisciplinary cancer care team to optimize biomarker testing, treatment, and management of adverse events in patients with advanced NSCLC, particularly those with ALK-positive NSCLC. As a reminder, each session will have an introductory presentation followed by interdisciplinary panel discussion and audience Q&A. There will be a 15-minute break between sessions. I'd like to pass the floor over to Lee Baumer, Chief Medical Officer of ACCC.
Thanks very much, Dan, and thank you all for joining us for this live virtual summit. I'm Dr. Lee Beamer, Chief Medical Officer at the Association of Community Cancer Centers, or ACCC. Just a little bit about our organization. We are the leading education and advocacy group for the cancer care community. ACCC is a multidisciplinary association representing 28,000 practitioners, from clinicians to researchers, hospital executives, administrators, advanced practitioners, financial advocates, supportive care staff, and more. ACCC is a community of cancer centers representing more than 2,100 private practices, hospital-based cancer programs, larger healthcare systems, and then select major academic centers across the country. ACCC translates clinical findings into how-to actionable items, designing quality and process improvement programs designed to help the cancer team accelerate integrations and effective practices, guidelines, new treatment paradigms, and technical solutions into practice. Please visit our website at accc-cancer.org to access several resources from today, and certainly opportunities to advance pathology practices and learn more about our work in this space. I'm really looking forward to us all diving into today's sessions. And with that, I'm going to hand it back to my colleagues at ASAP. Thanks.
We also have several faculty disclosures. The following faculty and steering committee members do not have any financial interests to disclose. However, we do have some faculty with financial interests. On the steering committee, we have Dr. Alex Spira, who was a consultant with Amgen, AstraZeneca, Merck, Mirati, Novartis, Pfizer, and Sanofi. And we have Dr. Brendan Stiles, who was a consultant or on the advisory board with AstraZeneca, Bristol Myers Squibb, Gala Therapeutics, Genentech, and Pfizer. For the faculty, we have Ms. Gina Hollenbeck, who was on the speaker with Bayer and the advisory board with Pfizer, as well as Dr. Sandeep Kandar, who is on the advisory board with AstraZeneca and Boston Scientific, a speaker with Aris Robotics, and on the advisory board and an international PI for Medtronic. He also does own shares of stock in Cardinal Health, Eli Lilly, Fresenius, Johnson & Johnson, Merck, Oncocyte, Pfizer, Sanofi, and Transcentrix. We have 2 other faculty, Ms. Kimberly Rohan, who was a speaker with AstraZeneca and Genentech and on the advisory board with Takeda, and Dr. Julia Rotau, who was a speaker or consultant with AbbVie, AstraZeneca, Shaite Tianquin, Curioscience, and Pfizer. Thank you for hearing out those disclosures. This activity is supported by an independent educational grant from Pfizer Incorporated.
In where I'm at, I'm from Greensboro, North Carolina. I'm the thoracic oncology nurse navigator. And I would say to kind of focus more on like the pre-workup, I think that's what we're going to talk about in the very beginning. And so when I introduce myself to these patients, most likely they don't have tissue diagnosis and they're metastatic. And so the connection that I can make with these patients early on really makes a huge difference in them understanding treatment options, adhering to treatment. So again, focusing on this patient population, making this connection can really help their journey a little bit better through their cancer care.
Thank you, Dana. I'll go ahead and start your presentation.
What is navigation? And so it's very different in every cancer center. I've talked to different navigators. I've been a navigator at our cancer center in Greensboro for the past 10 years. And so our navigation really starts kind of before tissue diagnosis and kind of takes the patient through their journey. But once they're kind of in with the health system, they don't need us as much until there's kind of a transition of care. And what I mean by transition of care is like their treatment options are changing, or they're not tolerant of what they're taking right now. So abnormal findings are what we talk about with the patient when we see them. We kind of expedite their care. That's what navigation really does in this community, is kind of identify these patients, expedite their care so they can get on treatment plan as soon as possible. The sooner they get on treatment plan, the better outcomes that they're going to have. Again, connecting with the families, I think, is really very key for navigation. It really, if the patient can understand what's going on, the next steps, who to call, when to call, side effects, and that kind of information, they're more apt to really do that. Also, if they can have a care person, like a care provider, that could be a spouse, a partner, a family member, because it really kind of is like a team effort for these patients to get through their cancer journey. It's not just, we're dealing with the patient. We deal with the whole entity, and connecting them to resources in the community. A lot of cancer care can be very financially toxic. So we talk to them about trying to find resources, making sure they have insurance. But again, I think I'm digressing a little bit. Sorry about that. So to focus again back on before the tissue acquisition, we're talking to these patients. They're hearing the C word. So they're very on edge already. We show them their scans. We tell them the outline of the treatment plan, and then we refer them. We refer them to pulmonary or thoracic surgery or interventional radiology to get the tissue that we need. Most of these patients are talked about at cancer conference. We have that weekly for thoracic patients, and we can get them before diagnosis and talk about the best way to obtain tissue, because right now with lung cancer, we want to get the most tissue we can get. So we talk about least invasive, but getting the most tissue. So that's really kind of all I have regarding kind of this pre-tissue acquisition information. Is this just the connection again with the patient, trying to kind of put them at ease, tell them what we're doing, and to go forward and make that plan. Because once they hear this, that they've got cancer or that looks like cancer, they want to just expedite and get stuff rolling as soon as possible. And we do too, because we want the best outcomes for them.
Thank you very much, Dana, and thank you, Michelle, and the rest of the team here. I was asked to talk a little bit to this group about tissue acquisition. So, by background, I'm a thoracic surgeon. I practice at the Virginia Cancer Specialists group here in Northern Virginia, in Fairfax, Virginia. We're part of the U.S. Oncology Network. So, tissue acquisition, exactly as Dana said, is something that's of course something that I do on a daily basis. So this is really what it's all about, right? So the pathological adequacy is of paramount importance in tissue acquisition. And I think that folks get very bogged down very quickly and overwhelmed in many ways with making the diagnosis, pursuing the treatment, and then maybe talking about recurrences and what's next. And especially the first time around, when a patient comes in for evaluation of a potential cancer, they've taken time, they've seen a primary care doctor, then they've gone to see a pulmonologist, and maybe they've come to see an oncologist, and nobody's yet gotten tissue, but they have a whole lot of radiographic imaging. People have ordered MRIs and PET scans, and that maybe we don't know exactly what type of cancer this is just yet. We have supposition, and tissue acquisition gets to be after they've already been down the road of many, many appointments already. And so tissue acquisition is generally something that we get put under the gun for, right? They've already waited a while. Everybody's told them they have cancer. They haven't confirmed it yet, but they want to know yesterday what they're going to do about this and what comes next. And so I break down tissue acquisition into three major categories. So the structure, when I think about a patient that walks into my office with a possible cancer, it's broken down into three categories. There's blood-based testing, there is needle biopsies, and then there's surgical intervention. And so, and this is the way I ask my referring physicians to think about things as well. Now, we're going to hear a little bit more about blood-based testing in subsequent talks, but blood-based testing isn't, at the moment, the gold standard and isn't enough to typically act upon it in isolation. There are a few exceptions to that, but in general, we're going to need to put some form of tissue on a slide, and a serum test, a blood test, is generally not enough in the realm of non-small cell lung cancer to make the initial diagnosis of cancer and then act upon that. I suspect that in coming years, that's going to change. And I suspect that many of the things that we do now in tissue acquisition will be rendered obsolete. So this thing is something that's here and is coming and is going to evolve, and is probably going to be the largest segment of what we do in the future, but isn't the largest segment of tissue acquisition at the present time. So then there's number two, and number two is needle biopsies. And I group it this way because there's a multitude of ways to get needle biopsies, right? So one can do a CT directed needle biopsy, and that's probably the most common way that a lung cancer is diagnosed. Somebody finds an abnormality on a CT scan. It may or may not be followed up with a PET scan, but a radiologist then goes and puts a needle into the tumor and acquires tissue on a slide. Adequacy is of paramount importance because in some centers, that initial needle biopsy is not a core needle biopsy. It may just be a fine needle aspirate. And so you do a fine needle aspirate and you may get the diagnosis of cancer, but you may not have enough cells to do complex molecular markers, or you may not have enough tissue to do next generation sequencing. And so you may get the diagnosis of cancer, but then you've rendered that patient the need for further testing down the road. So an FNA, in whatever microscopic means, that's sort of the most basic, least invasive way to get the diagnosis. So within this second bucket of needle biopsy, we put together fine needle aspirates, which can be done image guided, ultrasound or CT scan, or via bronchoscopy. Now, via bronchoscopy, there are a litany of ways to get tissue. One can use navigational bronchoscopy. One can use ultra-effective biopsies to biopsy not only the nodule, but the lymph nodes. And so you open up this large Pandora's box of how best to get tissue, because oftentimes what's easiest and most available is simply the core needle biopsy that the radiologist can get off a CT-guided biopsy, and that's why it's the most frequent. But that only gives you the diagnosis of the tumor itself. Now, if the CT scan also shows lymph nodes, it might be important to do a lymph node assessment for appropriate staging. So not only is tissue acquisition important for initial diagnosis, it's also important for staging. So can we do these techniques, can we do these diagnostic modalities in a minimally invasive way? And the answer is yes. And generally those tissue acquisition techniques are bronchoscopically based, where a bronchoscopist, and that might be a thoracic surgeon, that might be an interventional pulmonologist, that might be a diagnostic pulmonologist, any of these groups of people can go down the windpipe, diagnose the tumor itself, and then look at the lymph nodes at the same time and stick a needle in the lymph nodes, usually via endobronchial ultrasound techniques. The advantage to a procedure like that is that that is one anesthetic event, and you've done two things. You've both diagnosed and staged the patient, right? And then you have the third category, which is surgical intervention. So a lot of people move towards surgical on a needle biopsy. So why don't we just do an operative biopsy? And the operative biopsies are broken down into mediastinal disease and then lung disease. And so the tumor itself resides in the lung, the lymph nodes are in the mediastinum. Both of those can be approached surgically, but oftentimes that's the most invasive and usually done only if category 2 is not ascertained. There's all of these techniques to get tissue, but I would submit to you that the most important question is, what is the pathologist going to say about the adequacy of this tissue? And am I going to be able to answer all the questions that I need to answer? So it's not enough in 2021 to put tumor cells on a slide and call it cancer. We now need to know more about the molecular characteristics. We need to know about stage. So as you guys think about where to send patients for tissue acquisition, this is where multidisciplinary teams, navigation programs, and multidisciplinary programs really do fit in, so that patients can get to the right place at the right time and get the appropriate amount of tissue the first time. Thank you very much.
Thank you, Sandeep. Next, we have Timothy Allen.
Thank you. I am Tim Allen. I'm the chair of Mississippi at University of Mississippi Medical Center Department of Pathology, and I'm going to spend a few minutes just going over some basics of molecular process with focus on liquid biopsy. Those of you who live in this world, this may seem very standard, but I think for those who don't touch it that often, it's good to know sort of some extent the details in the black box of the laboratory that you may not come to mind so easily. Next slide, please. Thank you. We all know that right now there are several recommended targets in the guidelines for non-small cell lung cancer, EGFR, ALK, ROS1, et cetera, and the list continues to grow. Certainly ALK testing has been around for many, many years, and frankly should be performed on the same non-small cell lung cancer patients as EGFR. What I'm going to talk about with some particularity are the testing modalities for ALK testing. First of all, there's fluorescent in situ hybridization, or FISH, immunohistochemistry, which I'll go into a deeper dive in the second session, and of course the very hot topic, next generation sequencing, which sounds great, but is it really what everyone needs in every setting? I think the take-home message when it comes to testing of any sort, and in this situation, ALK testing in our patients, is that the testing must be relevant clinically. It's got to be easy to interpret, have as short a turnaround time as we can get, and also be cost efficient. I think those four criteria we need to kind of check boxes on, and then to use those to determine what the best modality for testing ALK is for our patient population that we have that vary around the country. Next slide, please. Now, again, those who live in the laboratory, these are basic terms, but for those who may not live in the laboratory, consider the words that we use often: pre-analytic, analytic, and post-analytic. This is where hiccups can happen. This is where problems can occur. Analytic and post-analytic are mostly on the laboratory and pathologists end. Certainly analytic, where we're talking about what happens once the specimen gets to the laboratory. How does it get batched? How do the reports get put together? Are we using appropriate methods? And then post-analytic, once the test is performed, is it available in the electronic record? How's the treating physician notified? These things are all issues that could cause problems. So These are potential errors we need to address. But in fact, it's the pre-analytic world that I think most of the folks can be more involved in, including laboratorians and pathologists, but certainly our clinical colleagues, our nurses, and on. And this has to do with ordering the test. How do we get the specimen? We just heard a whole lot of good discussion on having enough tissue. Well, that's a pre-analytic potential error right there. Slide and block review, if something's going to be sent away to another outside lab. How are things even transported to the testing laboratory? You put it in the back of a truck and it gets to be 110 degrees. Is that good or bad or indifferent? All those things have to be kept in mind. And those are pre-analytic testing issues. Next slide, please. Now, most biomarker tests are done in the community setting at the moment. And again, it's been alluded to already that things are changing, but most biomarker tests are now done with a single gene evaluation. This, of course, requires more tissue because it's a one-off set of tests, and it limits the number of tests done when there's limited tissue, which often there is with very small biopsies. You know, immunohistochemistry is done with these single gene evaluations for the most part. And it is, in fact, the usual diagnostic test for patients where we're looking for ALK change. And then we follow up with FISH testing when we have indeterminate tests. It's not strongly positive, for example. But we are seeing next-gen sequencing coming into play more and more with the panels that are being used, in which ALK testing is thrown in with a larger panel of several tests. And I think we're going to see more of that as the number of tests required for our lung cancer patients continue to increase. And so, of course, laboratories are starting to migrate away from single gene testing toward next-gen sequencing assays, putting these panels together that'll really detect a very diverse set of alterations. That's good and bad. Good, yes, it may help with turnaround time because it's all being done at once, although it does take longer to do than an immunohistochemical stain. And yes, you're doing them in one lab, but oftentimes you will get back a report that's in some respects uninterpretable and needs a lot of attention. So it's a mixed bag there. Again, the take-home point on how one should test in various scenarios is at the bottom here. It's driven by cost, the urgency, turnaround time is always an issue. Clinical and laboratory focuses, sometimes labs set up for it, sometimes not. Of course, time considerations, and at the end of the day, there's not a one-size-fits-all. Each team needs to look and say what's best for us and our patient population in our setting, with the goal of it being, as we've mentioned before, cost-effective, timely, et cetera. Next slide, please. So let's talk now about liquid biopsy, or if you want to use the fancy phrase, plasma genotyping. This is an evolving concept. It is continuing to evolve. It came along a few years ago, and it's becoming more and more utilized, I think more and more trusted, yet it does have limitations, as again has been alluded to already. What it does is it looks at the circulating tumor molecules or circulating tumor burden in the peripheral blood. And of course, depending on each individual patient's burden, there will be value or not value coming from that. There have been several reasons to do the liquid biopsy that have been given to me over the years, and I have them down here, and I think some are better than others. But in fact, I think a key one is the inability to get a biopsy or have enough tissue on a biopsy in order to do all the testing that needs to be done. Or, the tumor is in the bone, the brain, or somewhere in a little spot in the lung that's just hard to get to. In those situations, it may be prudent not even to biopsy the patient because of the potential risk, but go ahead and do liquid biopsy instead. Sparing a patient complication of an invasive procedure has been put forward as a reason to not do this. But in fact, these are risks we have to get tissue. And from my perspective, unless you have a patient who really is at high risk for some reason, basic risk has to be taken into account for biopsies because we need the tissue. Again, inadequacy of the biopsy tissue to perform necessary testing, that kind of rolls in with inability to biopsy because of the clinical condition or side of the tumor. Low cost of blood draw, I don't think is a very good reason. Yeah, it's less expensive, but the value of the tissue is superior, and we're talking about serious patient care here. Shorter turnaround time has been put forward as a reason, but at the end of the day, I think at the end of the day, it may or may not be a turnaround time issue. And finally, the circulating tumor cells are more likely to show up as part of a systemic tumor burden and not really focused on a single site within a biopsy. So you may get better information with that. Next slide, please. Very quickly, technical considerations, the devil's always in the details. EDTA tubes are easy to get to and you can use them, but the blood really has to be processed within about 2 hours. So that's great if you've got a patient who's there for in-house testing. Otherwise, you really have to use these preservative tubes. They're a little more expensive, but you can keep circulating DNA stable for up to 2 weeks, and it really works for send out labs. There's really no consensus on the amount of blood, but most people go without 20 millimeters. And of course, temperature and storage of this has to be very carefully watched. Next slide, please. So again, liquid biopsy is not the gold standard for ALK testing in our lung cancer patients. Tissue is, but it is becoming more commonly employed. It's not invasive. It's fairly reliable. It's a good alternative approach when you can't really get tissue for analysis. It may be great for evaluating recurrence in patients who may be more difficult to biopsy. And it's really driven molecular testing away from local path labs into central, often for-profit labs. Next slide, please. So I'll leave you with a few questions. What does liquid biopsy mean for patient care? How does it affect the pathologist role? And do we care if it affects the pathologist role? What are the implications for integrating this information into therapy selection? And how do we control quality when the testing is done off sites where we're not there? So thank you very much. I'll sit back and we'll discuss more hopefully in our session.
Okay, hi, good morning. I'm Dr. Presley. I'm a thoracic and medical oncologist and a geriatric oncologist at The Ohio State University. And I'll talk briefly about receiving the reports and treatment decisions, but the bottom line is it's complicated. Next slide. So, so lung cancer is responsible for 1 in 5 cancer deaths worldwide. And so this is a majorly growing issue. Next slide. And the reason why we're here all today talking about it. And really, I think this is a surprising fact for a lot of people is that it's really the #1 cause of cancer-related mortality, not only in the United States, but also worldwide. Next slide. And so previously, and even now, when we think about non-small cell lung cancer, that's like the big umbrella term, right? And underneath it, when we look at it under the microscope, we used to describe it just as these 4 main types. And as Dr. Allen said, now we have molecular subsets as well. So initially, we still do think of it as adenocarcinoma, squamous cell, large cell carcinoma, and other. But now underneath that, we have all these molecular subtypes as well. Next slide. So there are now molecular subsets of lung cancer defined by driver mutations. And this pie from mycancergenome.org is showing essentially the highest prevalence is really EGFR and KRAS right now. There are many others. And then a lot of them are still unknown, or we don't know. Eventually, there may be targeted treatments for them. But now it's become increasingly complicated. So anyway, moving on. So EGFR mutations are the most common oncogenic driver mutation, but we now know that there are mutations, there's point mutations, insertions, all different types of genetic alterations within EGFR that are being discovered. And now we are even seeing publications looking at lung adenocarcinoma genetic mutations in very, very small areas of the world. So this one recent publication was looking at the clinical pathologic characteristics in northeastern Switzerland, for example. So we have really had rapid fire approval of oral tyrosine kinase inhibitors for these genetic TKI subsets. So really rapid fire approval. And it seems every month now we are having more medications approved, which is a fantastic problem to have. Next slide. But it's easy to get lost in the cancer world. So if it feels overwhelming to both get the testing results ordered, get the tissue biopsy, it's complicated, and you get a very detailed report back. So I'm going to spend a few minutes going over big picture, what I do when I get this initial diagnosis for a patient for stage 4 non-small cell lung cancer. And these are the treatment buckets that I talk to my patients about right off the bat. Targeted treatments, chemotherapy and immunotherapy alone. So we do, again, standard of care, as the other doctors stated, is still a tissue biopsy. And that's really because of PD-L1 IHC, like Dr. Allen was describing. Once we get, and there was even a question already about why do we have to get tissue? So I would say, first off, it's because we do want to know if it's adenocarcinoma or squamous, because there are different treatments that we know are better for that actual histologic subtype. Then, regardless of the histologic subtype, we really need that PD-L1. And right now, there is no approved test for a liquid PD-L1 testing. And really, the majority of patients fall into the algorithm on the left, right? The majority of patients, as of right now in 2021, do not necessarily have a genetic driver mutation. So PD-L1 really dictates what we're able to give, and histologic subtype, those two, in terms of what are we able to give in terms of chemotherapy and immunotherapy, and whether we can give one or the other. And so this is a whole separate talk, and I'm not going to go into this today. But then on the right side, we absolutely need to know the genetic molecular profiling of the tumor. And this can be done either looking at the tumor tissue or blood. And we will send blood if tissue is unavailable. And there are a host of testing platforms, as Dr. Allen described. I'm not going to take a deep dive into those testing platforms. And there's also a big debate among thoracic oncologists in particular, whether or not you need both blood and tissue, and if it should be sent at the same time. That's also a discussion for another day. But if you do one thing, it's send testing for these 7 genes listed here. And I'll tell you why in the next slide. So, next slide. So I'm going to go over just my targeted therapies toolbox. And we don't have time today to go over every single study because there are so many TKIs approved now, but I'm going to give you really high level tips. Next slide. So here's my quick sheet for those 7 genetic alterations that I just showed you. And if you test for these, at least these 7, you are giving, this is a best practice. This is really gold standard care as of today in 2021. EGFR, ALK, ROS1, BRAF, V600E, MET, NTRK, and RET. And these all have an FDA approved preferred first line oral TKI that you can prescribe in your practice and for patients. Now, as our patient navigator, I believe, Dana did state, the number one, I would say, issue is tissue, but number 2 is cost. And currently, I would say the majority of Americans in particular do have, it does cause significant financial hardship. And this is a very hot area of research right now, looking at the financial toxicity of these medications. So what I've compiled for you here is the preferred first line treatment. And some of these, I know ALK is a particular interest. I would say alectinib would be my number 1 choice for ALK currently today, because it has, it's been around the longest in terms of, other than crizotinib, and due to its CNS penetration, or its ability to cross the blood-brain barrier. Brigatinib and lorlatinib have also been approved. However, they are newer drugs. The side effect profiles are different. So I would say, by and large, the most common medication that we are using at Ohio State right now is alectinib. But you can see how far we've come since the EGFR inhibitors were first under clinical development, back in the late 90s, in terms of all the TKIs that are currently available. Next slide, please. And I would say the most highly anticipated drug that's coming down is sotorasib for KRAS G12C mutated lung cancer and colorectal cancer. And this has received FDA breakthrough approval, but hopefully we will see it approved within hopefully the next 1 to 2 months for widespread use. Next slide. So due to time, I'm not going to review this data, but it's included in the slide deck for your educational enjoyment. Next slide. So I did in the quick sheet list clinical trials as an option for each one of these genetic driver mutations. And so I would say it's really a great idea to investigate clinical trial options in your area. For example, here's one at Ohio State. OSU is Ohio State University. This is a glutaminase inhibition drug plus osimertinib in EGFR positive, again, non-small cell after progression of disease on first-line osimertinib. So again, it's just an example. There are many trials with many different genetic alterations that are possibilities for patients. So I would say definitely look at the websites for possible clinical trial enrollment in your area. Next slide. But overall, it is easy to get lost in the cancer world. And so I would say, I'm going to go through now. So I'm a geriatric oncologist, and I really specialize in taking care of older adults with lung cancer. And I think one helpful tip can be thinking about the patient in front of you when you're trying to decide about which TKI and when. And TKI, again, is tyrosine kinase inhibitor, these oral medicines, once a genomic driver mutation is identified. Next slide. So there's a lot of heterogeneity within older adults. Some of us are exercising, blowing bubbles, super positive and happy, as we age, exercising, but then others of us are experiencing functional decline and disability. Advanced slide, please. And we may be experiencing frailty, depression, cognitive impairment. Maybe we need assistive devices or help to maintain our everyday living. So there's a lot of heterogeneity within the patient with lung cancer that you may be seeing in front of you in your office. And so it's important to keep in mind that the average age at diagnosis of advanced non-small cell lung cancer is 70, 71 years of age. So keeping in mind this heterogeneity allows us to actually personalize care for older adults. Next slide. Because older adults do have a lot of differences in these things listed here in the word cloud. And a lot of it comes down to organ function, other comorbidities, cognition, goals, and family support is the environment which they're living in. Next slide. So some quick tips to finish off are think about toxicity and the comorbidities that the patient is experiencing. For example, some of these newer medications like tepotinib can cause significant lower extremity swelling. So if a patient already has lower extremity edema, this might be something that you want to keep in mind and may make you choose a different agent. Diarrhea and dehydration can be pretty catastrophic for older adults and may end up in a hospitalization and functional decline. So supportive care when using TKIs is really important, particularly if there's a combination TKI option. This will increase the risk for side effects and toxicities. Many of these also cause can cause severe rash. And we know older adults' skin is different than younger adults. So something to keep in mind and to counsel your patients about. And then cardiac comorbidities. Some of these newer TKIs, like brigatinib, for example, can cause high blood pressure. So these are important things to think about in older adults who may already have high blood pressure. Also, many of them can cause bradycardia or other cardiac issues. So again, making sure you're following those and making sure you're documenting the comorbidities of the patient that's in front of you may help you choose one TKI over another. Next slide. The next tip is really brain metastases versus no brain metastases. And this is a big difference between our first generation versus second or third generation oral TKIs, particularly with EGFR, ALK, and ROS1. So it's really important to get that initial brain MRI to complete staging, because a lot of these you're able to actually treat the CNS disease with the oral TKI. So I would counsel you to absolutely make sure you complete staging with that brain MRI, because this may help you decide which TKI to start first. Next slide. And then finally, talk to your pharmacist. I think pharmacists are actually probably one of the most valuable resources that can be part of your care team when thinking about and deciding on a treatment algorithm, particularly for older adults. You have to think about drug-drug interactions. A lot of these TKIs are CYP3A4, and that's how they're metabolized through the liver and can cause significant drug-drug interactions. They also can be familiar with the Beers criteria in terms of which medications might you need to actually de-prescribe before starting the TKI. And then keeping in mind polypharmacy. When we're prescribing oral meds, not just the cancer treatment, but also what supportive care meds do you need to prescribe to make sure your patient experiences the least amount of toxicity? What do they need to have on hand to try and keep them out of the emergency department and hospital from potential toxicities? Next slide. So basically, these are, if you take away nothing, I'd love you to remember this slide. Test for at least those 7 genes and more if you have the capability. Think about brain versus no brain involvement, patient comorbidities, and pharmacy involvement. And with that, I'll take any questions in the chat and look forward to the panel discussion. Thank you.
I did get a couple of questions about insurance and it being covered if we did a liquid biopsy and if we did like a next-gen sequencing. And I have gotten it covered for a few patients. I do get pushback from insurance about that, but and truly, in the cancer center that I'm at, we have to send our next gen. We have to send all that out. So I can keep an eye on, is a liquid biopsy going to be ready before the tissue biopsy, and then I can cancel one of those biopsies if one comes back before, so they don't have to, the patient doesn't have to pay. It's just a time thing. I just don't want the patient to have to wait.
I would say the waiting. Oh, go ahead.
Please, Dr. President.
Yeah, so I would say the waiting is the hardest part. But I would encourage that it's better to start on the right treatment than to start the wrong treatment. And I think when patients come to us and we don't necessarily have all the information that we need, you know, they wanted to start treatment like yesterday, right? Yeah. But really making sure we have the tissue, we have the PD-L1, we have the genetic information, and try and calm those patients and their families down, because the sequencing of these treatments does matter. And you can really increase toxicity if you start something like immunotherapy and then switch to a TKI, for example. So it's not just that we're not doing it as like a scientific exercise. We're really doing it to make sure to minimize the toxicity to the patient. So I really can't stress enough how important it is to at least have those 7 genes back and your PD-L1 before you're starting treatment. But I totally understand it is completely anxiety provoking for everyone involved, including the physicians, right? Because we want to treat them ASAP.
I agree. And Dr. Presley, I also think you made a great point when you said how complicated it is for us on our end, and then us trying to explain it to patients and their families. It takes a process. It takes an educational process for them to understand. We're not, like you said, we're not trying to delay you. We just want all the information to give you the best care we can.
Given that the question is about payment, I think that I've seen it several different ways. I've seen folks say that getting paid simultaneously for tissue and liquid is not a problem. I've heard people say it is. So I think it may come down to the payer, et cetera. But you're getting, I think, down to a very significant issue, which is the turnaround time. We talk about it as it's a number, and it is, but it's a stressor, as you mentioned, not just for patients, but our physicians are under a lot of pressure to respond to sometimes extraordinarily sick, even dying patients, and weeks go by. This is not a slow-growing prostate cancer. We all understand that, and that's why working to improve turnaround time has got to be a key issue. But you also bring up an excellent point. At the moment, the key to success is explaining to our patients and their families, as hard as it may be, this is normal, bear with us, keep them in the loop, because if they're not in the loop, the anxiety just grows and grows and grows. This, at the end of the day, maybe where next generation sequencing ultimately takes over, because even though it's batched and it takes several weeks, one of these days it's going to get less expensive and faster than the one-off immunohistochemical stains that we're doing now. But for the moment, that's where we are. And in fact, our IHC stains and maybe follow-up with fish or whatever it may be, may actually give us an extremely quicker turnaround time than next-gen sequencing to reduce this turnaround time that's driving everybody nuts.
Dr. Patel, did you have a question?
Yes. Thank you all, first of all, for outstanding presentations. That was very educational. I had a question for each of the panelists. I was wondering if you could comment on your whether your institution utilizes ROSE, the rapid on-site evaluation, and what your experience with it is. Thank you.
I'll be happy to start with that. As the pathologist here, we do utilize ROSE, rapid on-site evaluation, for our needle procedures. There is value in ensuring, and it's been alluded to already, it's been talked about, there's value to making sure that we are actually in the lesion so we can get enough tissue, that tissue adequacy issue is hopefully taken care of. It also is important because, keep in mind, not everything is cancer. So if a needle aspiration is done and, whoa, this looks like it could be inflammatory, let's do cultures, or look at all these lymphocytes. Let's see if there's a potential lymphoma. These things can really help us a lot. It also, though, extends the procedure, probably increases potential complication rate because of the time the needle is in the body. But I think what we need to do is look at situations where it really serves the best and go with it. And in other situations, go straight to a core, because if it looks like a cancer, and chances are it is, it may be better for the maybe a fragile patient who may have bad complications to get the needle in and out, get the tissue. And then if it turns out it just happens to be all necrotic, well, we go to liquid or something. I've also talked to teams who have found success in working closely together and communicating, and this decreases the QNS situation, quantity not sufficient. So you got to measure it. I actually like to sit down with my interventionalists, both in radiology and pulmonology, about once a month, and we go over QNS percentages, QNS cases, and what we've seen is by just approaching it, talking about it, we've gotten better. and everyone's very comfortable. And if you got somebody whose QNS rate is 10% and someone's QNS rate is 40%, everyone's comfortable saying, let's help that guy who's doing 40% QNS to improve. But it does take, I think, communication. It takes trust amongst the team. It's not shame and blame. It's what can we do? Maybe this person's seeing tougher cases, but this will give us a tissue so we can move on it. Because remember, the pathologist has to make a diagnosis of cancer first, and that takes tissue. And sometimes there's tough, and sometimes we need immune stains just to make the diagnosis in order to pursue the appropriate molecular testing. So yeah, the tissue, as they say, is the issue. Here, I think communication with our interventionists and pathologists during a ROSE can be extremely instrumental in helping our patients who darn well don't need to go back and have another needle stuck in them when they're often in bad shape.
Does anyone else have a response to that?
Yeah, sure. I'll chime in as a surgeon here. I couldn't agree more with Dr. Allen. It's the reason I said it's really the pathologists that dictate the tissue acquisition. In our institution, both our interventional pulmonologists and our interventional radiologists both have ROSE accessibility and use it routinely to make sure that A, the tissue is viable, and B, that the quantity is adequate. So we use that. On the surgical side, I have to say I find myself using less ROSE. Mostly because at that point, it's not a decision maker, and I'm generally taking the whole tumor out, right? So if you're taking somebody to the operating room for both a diagnostic and a therapeutic intervention, the only time I find myself using a rapid on-site evaluation is if it's going to change my management in the operating room. So for example, when I get sent a peripheral nodule that is either a primary lung cancer or a metastatic head and neck cancer, I'm going to use that rapid on-site evaluation to see if I can make the differentiation between those two. And it can be difficult, and we put our pathologists under the gun a little bit because it can be difficult to make that diagnosis in 5 minutes while the whole surgical team is waiting. But that's the most frequent opportunity for us to interact with a pathologist in real time. And quite frankly, it's a lot of fun, and you really do see it brings the team together, and when everybody's talking to try to figure out how to get the best answer for this patient, that's what makes it fun doing what we do.
Well, what you point out is, in fact, the ROSE is just an extension of our well-known intraoperative consultation frozen section. It's just using smaller tissue, but it's there to help guide the proceduralist or guide the surgeon in the moment in determining whether to continue or stop or go one way or the other way.
And then I can weigh in. So our interventional pulmonologists use it, but our IR actually does not. And I actually don't know why that is. So I can actually find out why. But I love the idea of the QNS review. And that's a great point. And I actually will ask our IP docs if they actually do that, because my sense is probably not, because we do get quite a few QNS back from IP because it's usually, it's an FNA. So I think that would be a great point actually at our institution to improve that QNS review.
And I would say also, as a pathologist who also is boarded in cytopathology, which is the team that does these FNA reviews, I'm a fan, but I also recognize their limitations. So in fact, if we have a patient who, the radiologist has done the job and here's the lesion, the needle's right in the middle of it, I don't need an FNA. Get a core, get out, send the patient back, no complications. Then we got a big piece of tissue to look at. And to follow up on this, and I don't want to go too much in the weeds, but it's also very good practice to make sure that if you can get a interventionalist to give you 3 cores, 4 cores, each one of those has to go in a separate block, because if you put all of it in one block, you section through it there and you run out of tissue for biomarker staining, versus 4 blocks, 4 different pieces of tissue, hopefully all have cancer. You have a lot more, 4 times as much tissue to work up the patient than you would. So these sort of details we've drilled into our residents and our team. This is standard of care now. Putting it all in one block, it just can't be done. So all these details have really altered how we address lung cancer in the era of molecular pathology in the laboratory. in an intent to look at the tissue as precious as gold. And every bit, every slide has to be accounted for.
Absolutely. And Dr. Presley, I appreciate what you said about the interventional pulmonologist. You know, when you're doing FNAs of bronchoscopically, that the amount of tissue you get, I mean, every time you're passing that needle through the bronchus, you're putting that patient at risk for a pneumothorax, right? So it all of this is really dependent on the skill of, as Dr. Allen said, your cytologist and your pathologist, and there are definitely differences. I've taken samples from one pathologist, shown it to another, and one will say, absolutely, this is non-small cell lung cancer, and another one will say, no, we can't really tell. So much of this is institution specific, and much of this is how aggressive are the interventionalists that you're dealing with, and this is where the conversation is just so very important, the collaborative approach. We found ourselves moving more and more away from the FNAs and the bronchoscopic interventions and towards the core needle biopsies, because as Dr. Allen pointed out, you can get 4, 5, 6, 7 cores. And if you're looking for a neoadjuvant clinical trial or looking for an adjuvant clinical trial, they oftentimes need quite a bit of tissue. And so a CT guided core biopsy can do that. The attractiveness of doing it bronchoscopically is that you can do more than one thing at a time, but that then comes at the potential downside of the smaller tissue sampling. So it really does depend on what you're after. Are you, how important and how much tissue do you need, and how important is the staging in that particular intervention?
Thank you. So we do have a question here. It says, do you recommend reflex testing for these tests? If so, how have you recognized, or how have you organized it at your site?
I'm just going to speak first because I'm the surgeon and I'm not the smart one. So I'm going to let the smart doctors weigh in on that one. I defer to them.
Well, Dr.
I wish
Presley,
we had, yeah, sure. I wish we had reflex testing, but because I think it would speed things up, but that requires knowing if the testing has been conducted elsewhere at like a different institution, and to avoid the double billing of multiple tests, particularly these more expensive NGS testing. Our pathologists do not feel comfortable doing reflex testing because we're such a big referral center. A lot of times we have to call the referring office because they've sent the NGS tests already. So then we actually have to chase it down, and then we don't want to double bill the patient. So I would say if you are pretty confident that no one else has ordered the tests already, then maybe there is a role for reflex testing, especially for adenocarcinoma, because at least for the genetic testing for adenos, if you're fairly confident that patients aren't getting it done at an outside institution. However, if you're a big academic referral center, the hope is that the referring center already ordered that testing. But then we do have to track it down, right? And I think that's probably the number one issue right now, is that a lot of these testing results are getting faxed, like via PDF, and are not integrated into the electronic medical record. And so you're waiting and it'll get sent back to the ordering physician's office. So then we're actually calling multiple times to get that testing result, unless we have direct access to the testing platform portal. So I think ideally, yes, we would have reflex testing accessible at wherever you're getting a biopsy, there would be reflex testing available, but we're not there yet because I think of limitations of integration of our healthcare system.
Well, of course, Dr. Presley, the smart doctor, answered 100%, but all I can add to that is at a place like the University of Mississippi Medical Center, where yes, we get referrals, but most of the patients we see are direct to us. So we don't have Dr. Presley's issue of it's already been done most of the time. We still do not do reflex testing, even though I'm a big fan, because of the cost. Some people, I think some institutions are happy to eat the cost of those who don't need it in order to get the time benefit. Others don't. And, being post-coronavirus pandemic, with the financial consequences, there's not an appetite here to eat testing that doesn't need to be done. So we're still dealing with a prolonged turnaround time. But as a pathologist, it just makes good sense. Adenocarcinoma of the lung, go in the EMR, click the buttons, get the molecular going. I think we need to get to that one day. Again, we're seeing, as you mentioned, a huge electronic medical record tangle that has to be overcome. We got to get there. We got to get the cost down. And then I think reflex is got to get here, because that is going to be a significant factor in shortening the turnaround time on our patients.
Yeah, I agree with you on that as well. We don't in Greensboro, we don't reflexive test. And to Dr. Presley's point, like, I'm the navigator, so I'm the one calling and tracking down these moleculars and trying to find the right person, and asking the patient about that, and they're just not sure if that's been done or not, because they just don't understand that process. So yeah, I would love to see reflective testing, but we don't have that.
Okay. John Carney has raised his hand. I'm going to allow him to talk.
I just wanted to say thanks for a really wonderful talk. My name is John Carney. I'm one of the thoracic pathologists here at Duke University in North Carolina. Dr. Allen, nice to see you. I know we've talked and met a few times, so it's nice to see you. I just wanted to put a plug in again as a pathologist to some of the things that Dr. Allen had mentioned. Communicating to your pathologist, at least in my mind, has been a really important tool that we use here, and just having good and open lines of communication about tissue type, tissue sampling, what we can and can't do, what the clinicians are trying to get from us, and what we can offer to the clinicians. The communication that we have between our oncologists and our surgeons, both in the operating rooms as well as our pulmonologists and our on-site evaluations, I think really helps streamline how we procure tissue and how we get it to the right place. I often tell our residents, pathologists are not passive, pathologists are active, and really having an active role in directing the tissue and which direction to go with it is really important. I actually had just given a talk a couple of weeks back about essentially this topic, procuring and preserving ancillary or tissue for ancillary studies, and really minimizing the work that we're doing, ordering stains and cutting through the block to really give you, the oncologist, the information you need right up front. And then that way we preserve every bit of tissue that we can for ancillary studies. And I think that that's going to become even more important than it is now, just as we keep going down the line. And so I think I would put a plug in for folks that are in places in which the communication to the pathology department is not quite as robust. Just reach out and see what can be done, what kind of workflows can be established, what kind of things are you seeing that maybe we're duplicating orders, or maybe one tissue specimen is not being utilized appropriately, or just trying to find those things that might be able to better save tissue and really maximize what we're getting from the patients. Because like Dr. Allen said, we don't want to have them go back again, and we want to do what we can to provide as much information we can for the patient. So I just wanted to say a really nice talk, and appreciate you all taking the time to discuss this.
Thanks for that comment. I did want to mention, so one communication thing that we did implement here, because we're a huge university and things get lost in electronic medical records. And so one thing that a practice change that we did make was we did ask the pathologist if they do get an actionable, at least EGFR or ALK back, to actually page the ordering oncologist, because it has such profound treatment implications that it just ensures that that result does not get lost in the shuffle of crazy clinical practice. Because then we do track down, the patient might be hospitalized, they might be about to start a different treatment, but then we're able to intervene in a timely fashion. And at least for those 7, they've been agreeable to at least, EGFR, ALK, ROS1, and the big 7. But it really, that's one thing that we've found, almost like the radiologist paging you for an acute, appendicitis or something, or a new brain met, right? Having the pathologist page us if an actionable driver mutation is found, at least, within a short list, has actually, I think, improved our time to treatment.
What you're saying, but what my perception of what you just said is, as a pathologist, is there is a potential post-analytic testing error, which is communication to the treating physician does not occur at all or in a timely manner or gets lost. How do we fix it? Well, we fix it with a solution with direct communication. So what you're doing is avoiding a post-analytical error that could occur in a testing situation. So again, my brain works in terms of pre-analytical, analytical, and post-analytical, and this is a good example of a post-analytical situation that you and your team responded to.
So keeping in that communication going, or that topic going, this section was really about the communication between the different departments. I love your segue, Dr. Presley, into some changes that you made. Have anybody else on this panel made some a significant change, or is there a change you would love to see within your institution to kind of keep those lines of communication open amongst you all?
So historically here, our tumor boards in a community practice, our tumor boards were run on a monthly basis. And very quickly over the last several years, we realized that a monthly review is not enough. That monthly review basically became an interesting case conference where we would bring up, tumors that had interesting mutations and responded dramatically well. And it was more of a show and tell conference. And so we've transitioned all of that into, it's a weekly conference, and everybody comes, the med-oncs, the rad-oncs, the pulmonologists, the pathologists, and we literally just go through every case. It's rapid fire, it's very quick, but this ensures that we are looking at all of the cases that have been seen in the previous week. And then separate to that, on the surgical side, right after that conference, we do an in-depth path review of all of the cases that were done in the previous week. And so we've sort of taken that two-pronged approach to just make sure that nothing falls through the cracks, because as Dr. Presley said, it is overwhelming in clinical practice, and the numbers are going through the roof in terms of biopsies and resections, and it's a lot of information to manage. I think that folks like Dana are critical to any program. We're lucky to have folks like Dana as well to help us organize it, but it's a daunting task, and I don't know that any one practitioner can manage it.
One thing we've done here at the University of Mississippi Medical Center just recently, actually, is as we're kind of coming out of the coronavirus pandemic and getting our wits about us again, is we recognize that things are evolving. It's a dynamic situation in lung cancer, molecular testing and therapy. And it, by the way, is dynamic in colon and endometrial and all these other things. So recognizing communication and understanding is key. We've developed what we call the Molecular Diagnostics Stewardship Committee, in which we have stakeholders from around the institution get together, and we talk about various issues that pop up. We basically work to standardize what needs to be tested, how, when, et cetera. And it's not just we have really two subcommittees. One is cancer, one's genetics, because they're kind of different worlds. But we want to make sure we're working in a standardized fashion. Not only do I think it helps make sure that we're using up-to-date evidence-based literature, current technology and techniques, but it also helps us focus on potential disparities, because there's always a risk that someone falls through the cracks because of insurance or whatnot. So by standardizing, I think that helps protect to some extent. And by the way, we also know a lot of people with lung cancer never get tested, or if they get tested, they don't get treated. By standardizing this and having a stewardship committee discuss odd cases or whatnot, I think it does help move us forward and also prevent that sort of I got to do something philosophy. We'll just give them some of this or some of that. In fact, we're not here to do research without an IRB. We're here to take care of patients in a manner that's standard of care, and we can do a lot more to meet the standard of care before we start wandering off on some weird mutation that may most likely have nothing to do with benefit the patient. So we just started just a while back. We're going to see it going, but it does take buy-in by champion stakeholders that they also recognize that working as a team is how we're going to solve the problems.
Anybody else? We do have another question. It says, have you standardized reports to oncologists, and what's the best way to present the written information?
Well, as a pathologist, we do report to our colleagues in a written form, sometimes in a verbal form. One thought I have regarding the question is a lot of testing is done out of the institution. Often big laboratories, for-profit laboratories do these. And as I know, and you may know, you often will get back into the patient's record a 80-page document that doesn't have a good synopsis of the actual markers that are current standard of care. I think this is a good opportunity for pathologists to be involved. But by the way, if the test is liquid and it goes out of the clinic and comes back to the clinic, I'm not anywhere near it. I don't know it exists. That said, I think that it's important for pathologists to do their jobs, which is to communicate to our colleagues. And by the way, the patients now, because everybody's got one of these and is looking at their medical record, to communicate in a way that everyone can understand and take action on these markers, not just give a number amongst 60 mutations that were examined or some nonsense, but in fact give real time information that can serve immediately the patient care. Again, what happens when it doesn't hit the pathologist's desk or doesn't come through the in-house laboratory? You're stuck with whatever comes down from the outside laboratory, which can be confusing. At the end of the day, I think one opportunity for all of us is to work towards standardizing language, standardizing reports so that we all can be comfortable. This is what we need, but also be nimble enough that when the FDA jumps up next Friday and something else rolls in, that we're able to incorporate that into our new standard and move forward.
We do have, we have 7 minutes left in this discussion. I see that we got a comment from David Waterhouse in the chat. It says, in a community setting, we may be working with nearly a dozen different hospitals. Getting cooperation on reflex testing is formidable. Hence my interest in liquid biopsies. How many actionable mutations are we missing? Does anyone know the miss rate? Assume we've already had a PDL1.
I'm going to jump in again. I don't mean to hog the show here, but these are pathology folks, I think. My first response is I feel your pain of working amongst a zillion different institutions, zillion different ways of doing things. The communication, it must be a nightmare and almost intolerable. These are things that we need to get past. How, I don't know, we can talk about it. But at the end of the day, the tissue is still the gold standard. So if the reason we're not getting tissue is because it's just too hard, because there are too many involved, we need to address that first. How do we communicate? How do we work together as a team to get the tissue, get it where it belongs, get it tested? And yes, use liquid biopsy as appropriate, but to default to liquid biopsy because it's just too burdensome communicatively wise is, yeah, it's the world you're in now and you have to do it. I understand, I support that, but I would say going forward, be a champion stakeholder in getting the teams together to come up with a way that you can minimize that communicative issue and get to the tissue. I didn't mean to rhyme that. Get the tissue where it needs to be done. At the same time, further in your question, I can't tell you as we sit here today what's being missed in liquid biopsy versus tissue, or what's being missed in tissue biopsy versus liquid. One of the things to keep in mind is lung cancer is very heterogeneous. So liquid should show more of a systemic picture, whereas a core biopsy shows you what you have in those cells in that piece of a big tumor. That's a trade-off. On the other hand, liquid may not show certain things that are not shedding. The tumor burden is not great enough. So all that's being studied very closely. I think that ultimately we're going to see more use of liquid biopsy as we work these things out. But your questions are very prudent, but I don't really have the answers to consider today.
Dr. Allen, could you comment on ALK? Because I feel like that might be the one that with liquid, we're just not, it's not necessarily sufficient. But could you, because it's so important and we have so many treatments, it'd be great if you could comment on ALK specifically.
Well, I think you just said it. I think liquid is developing with ALK, but again, if you have a patient who's a potential candidate for target-based therapy with ALK, you want to know that, and that's why tissue needs to be gotten. The good news with ALK is an IHC stain can be done in a day or two. You got an answer, and you can start therapy. And in fact, if you need to back up the fish, you can do that pretty quickly. I'll get into this afternoon about the values of IHC, one of which, by the way, is you can get it done fast rather than waiting 2 weeks for next gen sequencing. Again, liquid, we'll see where it goes, but I don't know if a patient with non-small cell lung cancer necessarily is gonna get much information with liquid regarding ALK as I think they need to. Again, the key is try to get tissue at least the first time around before recurrence. I'm actually a fan of getting tissue at recurrence because really it's a new tumor. But again, situationally, it may not be a good fit for the patient. But if possible, yeah, let's get more tissue at recurrences and look closely. Maybe one day the hybrid liquid biopsy tissue may be the norm because maybe both answer different questions and we overcome the heterogeneity problem.
Okay, we just have a few minutes. So the panelists have any a single pearl with regards to following the tissue or communication amongst the different teams within your institutions that we can leave the audience with? I put you all on the spot.
I can start. I'd at least get EGFR and ALK before you start treatment for stage 4 non-small cell lung cancer adenocarcinoma. That would be my big pearl.
My take-home pearl for this morning is tissue adequacy, payment. Well, I have several. Tissue adequacy, payment, turnaround times, strong communication. These are the talking points I think we need to focus on as we continue to try to improve our patient care.
I would say just collaborate, and listen to your pathologists. They're the ones who have all of the answers.
I agree. I just think communication and collaboration is key. I think to have one person as kind of a point person for all of the disciplines, to be a navigator or a nurse or a coordinator, or whomever you want to call them, it can also really be very beneficial to track down these moleculars to make sure everything's kind of flowing, and again, to communicate with the whole team.
Absolutely. I think our nurse navigators are the unsung heroes in a lot of what we're doing here. And my hat's off to them. And we're so proud of them that we're working right now in the Department of Pathology to develop a pathology navigator to mirror that nurse navigator. Again, for better communication, a streamlined approach, save time, get it done.
Thank you.
I agree, Dr. Allen. I think a navigator with path department would be very good for these patients. It would help us. It would help them. It would help the whole team. Yeah, I agree.
Thank you to Ms. Dana Herndon, Dr. Sandeep Kandar, Dr. Timothy Allen, and Dr. Carolyn Presley for your presentations and wonderful discussions.